It's April 4th, 2025. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. And before we get into this week's podcast, I have a correction. I made a mistake. Shame on me. 2 weeks ago in our podcast and online on X, or as we know it, Twitter, I incorrectly described the study. It was my report from the American Academy of Dermatology on the Phase 3 Iconic Lead study. It was really a report about J&J's oral IL-23 inhibitor called icotrokinra. And in that report, I said it was superior to deucravacitinib. That was wrong. It was actually studied against, in this phase 3 trial, against placebo and shown to be highly significant, 65 versus 8% in total skin clearance, PASI 90, 50 versus 4%. Again, it's the oral 23 inhibitor versus placebo, not deucravacitinib. And also the primary endpoint was week 16. I reported week 15. It was an off week, you know, and don't worry, there's going to be a lot of reports in the future about deucravacitinib, both in psoriasis, it's already approved for, but more coming up on it in psoriatic arthritis. But I wanted to make that correction because that was incorrect. This week, we've got a lot of interesting stuff. I want to begin with a matched cohort study of RA patients, almost 80,000 RA patients. And in this very large data set, they were trying to make the point that that there are a lot of avoidable hospitalizations amongst RA patients. So when they looked at these RA patients versus controls without RA, patients had a 12% increase risk of avoidable hospitalizations, which they describe as ambulatory care sensitive conditions. These are things that should be well managed as outpatients and should, if they're well managed as outpatients, not end up in the hospital. This includes seizure disorders, chronic lower respiratory disease, asthma, diabetes, CHF, pulmonary edema, angina, right, as examples. They said the predictors were, for these avoidable hospitalizations, were age, steroids, having these comorbidities. And it really is a call for ambulatory care access and better primary care management can reduce the risk of these disorders, avoidable hospitalizations, which bring significant morbidity, mortality, and cost to healthcare. A Korean nationwide cohort study of almost 900,000 people with newly diagnosed osteoarthritis looked at the safety of nonsteroidals. We don't use as much nonsteroidals today as we did during my fellowship, but still they're out there. And this study did underscore the things that you know about the risk of nonsteroidals in OA, cardiac, GI mainly, hematologic, etc. But talking about nephrotoxicity, they weren't quite all the same. And I thought that was a little interesting. And just to give you a little perspective or comparative risk assessment, if you will, that the lowest risk, which was not higher than its comparator arm, was meloxicam with an adjusted hazard ratio of 1.22, and the confidence intervals overlap 1, saying it wasn't any higher. However, it was higher with other non-steroidals, loxoprofen, celecoxib, and naproxen, each of those having hazard ratios being almost 4, 2.4, and 4.7, and those were significantly elevated. So there are differential risks. I wouldn't have guessed, honestly, that meloxicam has a lower nephrotoxicity index. I often wonder whether this is related to duration of use, but more importantly, the dose that's being used. But I thought it was important to at least throw this up for you to consider. The EMA and the U.S. Are on a fast pace for approval of biosimilars in 2024. The EMA approved 28 new biosimilars, mainly for cancer, more so than musculoskeletal or immune-related disorders. but it was for cancer, osteoporosis, macular degeneration, and immune disorders like psoriasis, ulcerative colitis, Crohn's disease, etc. In the United States during 2024, we had 18 new approved biosimilars. Again, this is a big deal, and it's going to change the way we treat patients. Right now, there's 70 biosimilars approved in the United States, with more for oncologic indications than for rheumatic, but we're pretty close actually. And that makes the next bit of news even a little more interesting. As you know, that biosimilars have been around now since, I think, for about 15 years. And there was a recent FDA review of the legislation that led to that. And you know that biosimilars get onto the market with an abbreviated course for development. You don't have to do as many studies. You don't have to do it in all the indications. You have to do one bioequivalent study as far as the primary endpoint clinical outcome. Interestingly, this week, the EMA has proposed a new pathway for biosimilars, suggesting that we don't need to do the clinical trial anymore. Usually it's a large clinical trial showing that the PASI 90 score was the same with both the reference product and the new biosimilar, or that the ACR 20 was the same, et cetera. They're saying as long as you show structural and functional comparability along with the pharmacokinetic data and the drug interaction data relative to a reference product, that should be good enough to get a biosimilar approved. That's a game changer. Now, that's up for discussion in Europe, and that's not been discussed or proposed by the FDA here in the U.S. But it'll be interesting to see where that goes. A review article out of Taiwan Dermatology Journal says that something that you probably know, but maybe you don't, and that is adding methotrexate to a TNF inhibitor increases the efficacy of two drugs over one drug, and that's for the treatment of psoriasis. Adding methotrexate TNF increases the efficacy. But there's limited data, but some data saying that adding methotrexate to an IL-17 inhibitor or an IL-23 inhibitor may have positive benefits, more positive benefits to psoriasis. However, conversely, in psoriatic arthritis, not so much. Adding methotrexate adds no efficacy. Methotrexate to a TNF inhibitor adds no efficacy compared to the biologic monotherapy alone. And that's kind of the frustration of managing psoriatic arthritis. A nice review article from the NIH Division of Complementary Medicine on music therapy and its benefits in patient management. I found it interesting. I've really never considered music therapy. I thought my music therapy was some guy named Led Zeppelin, and that was good enough. Led Zeppelin, Jackson Browne, Warren Zevon, Linda Ronstadt. Yeah, I kind of listen to all the same stuff. I'm sure you do too. Music therapy is not quite simply performing music or listening to music. It's actually being seen by a professional music therapist, not Jackson Browne or whoever you listen to, and that there is a specialty for this. And that interventions in music therapy have been shown to be beneficial in managing anxiety, depression, pain, chronic pain, dementia, MS, and Parkinson's. I found it interesting because I've never considered it. And I think we should be knowledgeable about these non-pharmacologic interventions and find out how they will work in our patients. Because, as you know by now, your best medicines don't always work, do they? And maybe an intervention like music therapy is something to consider. A study in Alberta, Canada, looked at travel burden for the management of rheumatoid arthritis patients. They found and this is in Western Canada, there's more rural space, that on average, the median time for a patient in that jurisdiction takes 13 minutes to get to their general practitioner and 34 minutes to get to their rheumatologist. However, there are significant differences between urban areas and rural areas. And if you look at rural areas, it can be 4 times as long to get to the GP and 8 to 9 times as long to get to the rheumatologist. And this is a little disheartening. However, they did show the surprising result was that despite these differences in travel time, travel delay, if you will, travel duration had no effect on the utilization of health care, meaning patients are motivated to get your health care, to get your expertise. Again, these sort of numbers should be another endorsement for remote patient care, telemedicine, etc. 2 things on steroids. A review in Rheumatology about diagnosing PMR, where they pointed out that about half the cases of PMR out there are given steroids before they ever get to a rheumatologist who makes the diagnosis. That seems about right, given my experience in this arena. But then they looked at what's the influence of steroids and steroid use prior to getting to the rheumatologist, and it dramatically reduces the sensitivity of how we make the diagnosis using parameters that you all know how to use. And I won't go into the numbers here, but if you get them before they're on steroids and you employ usual methods, you have a sensitivity specificity is well over 80%. But if the patient's on steroids, that drops quite a bit. And this was analysis based on case report forms of 60 patients prior to steroids and another cohort that were also with PMR or suspected PMR who got steroids. And again, they found that, getting a patient prior to being on steroids made an easier diagnosis. But I think that's important to know that when you see patients on steroids, obviously a medical history is probably going to be the most important thing that you do, is it not? So another interesting steroid, I kept seeing a lot of reports this week about a new dissociated steroid compound. I don't know what that means, but it's a different steroid compound. It's supposed to be safer. It's called vamorolone. It's a promising alternative to traditional steroids that you use, prednisone or prednisolone, in the management of inflammatory diseases. This particular report that we put up this week showed its use in an animal model of a mouse model of inflammation, showing that it was equally effective at its anti-inflammatory potential, but that it had less steroid side effects. And, we've seen reports of new steroid compounds being developed that could possibly be better than the ones we're using, and they never quite pan out. And when you look up this drug, vamorolone, it's actually FDA approved for the use of Duchenne's dystrophy, right? In both kids and adults. It's incredibly expensive. Use it at the higher dose, it could be $70,000 a year. But it's a new steroid, and hence it's going to have a higher price. It's got a restricted indication. And the question is whether we might see a steroid like this in our inflammatory diseases. When you look at the reviews on this drug, this was only approved, I think, in 2023, that it shows that it does have less glucocorticoid toxicity, and it does seem to be as effective. But the question is, how will this perform in our patients, especially if we're going to use this at higher doses? So that remains to be seen, but I thought you should know there is another one on the horizon that's under development. 3 more reports. One on Still's disease. First-line biologics are the preferred therapy in patients with new onset or flares of Still's disease. And we're talking about mainly systemic disease, fever, rash, serositis, crazy labs, etc. This is a German multi-center retrospective study that looked at patients enrolled, like over 200 patients enrolled over, I think, a 15-year period. And they had 86 patients for evaluation. Half of them received either a IL-1 or IL-6 inhibitor, tocilizumab for IL-6. Anakinra was a dominant IL-1 inhibitor with some canakinumab, but mostly anakinra. 89% of patients received an IL-1 inhibitor, and 11% received the tocilizumab. And half received conventional DMARDs, which was steroids and methotrexate. And patients were assessed at week 12 and 72. These people, when they went on this, were not on pre-existing therapy or glucocorticoids. And the primary endpoint was sustained event-free remission, which meant normalization of CRP with no evidence of rash, arthritis, or fever or complications. And it was a slam dunk for the biologics. 50% of people at week 52 with, this was adult Still's disease, all right, not kids. 50% had this primary endpoint of sustained event-free remission compared to only 12% with DMARDs. If you used a IL-1 or IL-6 inhibitor to treat these patients, as you should, there was a 7-fold greater odds of achieving that endpoint. You know, this is evidence in support of the EULAR press guidelines on managing Still's disease in both kids and adults, and the ACR guidelines on managing Still's disease. Both of those guideline sets, done at different times by different groups, have in there that the treatment is an IL-1 or IL-6 inhibitor at the onset, plus or minus steroids, right? While you write the prescription, you can give them steroids and then give the drug the next day, that evening, whatever. But that is the way to go, and that's why I published this. I found this other interesting publication from BMJ. It's a consensus guideline on the management of chronic spinal pain. This is chronic spinal pain of more than 3 months duration, so it's not acute back pain, acute spinal pain, but more than 3 months duration that is not associated with cancer and not associated with inflammation or inflammatory arthropathy. This still is a tremendous number of people in the general population. So the prevalence of chronic low back pain of greater than 3 months duration is 4% in adults between 24 and 39, and 20% if you go up to age 59. In 2016, in the United States, we spent $134 billion in the management of low back and neck pain. So this is a big problem. This guideline panel, multidisciplinary, multinational, had patients on there, basically throws a damper on all the things that you do. So they say relative to sham procedures, things that you commonly do like epidural steroids, et cetera, not proven to work. So they are confident in their guidelines and stating that with moderate certainty that in treating chronic axial pain, epidural injections with an anesthetic, with or without steroids, don't work. And that joint-targeted steroid injections also don't work. That means facet injections. And that for the same goes for radicular spinal pain, that epidural injection of anesthetic with or without steroids, and dorsal root ganglion injections or radiofrequency procedures had no effect on pain. That's a big industry. I just had a relative that just got referred for one of these procedures this week. But this is comparing, studies where there was a sham arm, right? Which basically says most of these people are going to get better with time and movement, right? So whether that's going to change your therapy, I'd like to know. The big report this week in New England Journal on Thursday was the SELECT GCA study, a phase 3 trial featuring upadacitinib in patients with GCA. 209 patients were enrolled in this trial. 70% had new onset GCA, and they were randomized to receive either 15 milligrams of UPA versus 7.5 of UPA versus placebo, with a pre-specified 26-week steroid taper. In all patients, the primary endpoint was sustained remission at week 52, and that was 46% with 15 milligrams versus 29% with the placebo arm. That was significant. The 7.5 milligram group was not significant compared to placebo. It was only 41%. Not that different than 46, but it did not achieve significance. Based on this data, I would assume this is going to go to the FDA for a decision for a new indication for upadacitinib. That's it for this week on the podcast. I want to remind you, you will see announcements for, you can sign up to receive on-demand access to Room Now Live content with something like 22 lectures and 10 TED Talks and a lot of content, 5 panel discussions, etc. We had a bunch of people that signed up after the meeting to do that. You can do that as well. If you have got a case you'd like me to discuss here on this podcast, please go to the website, lower left-hand corner, click on Ask Cush Anything, record your case or question, and we'll discuss that here in the future. I want to give you a heads up. In the month of May, we're going to do a campaign on lupus. We're working on that right now with a lot of great lupus content. It's really exciting. It's coming up in May, which is Lupus Month, as you know. That's it for this week. We'll talk to you next. Take care.